I do act as a speaker for Castle Biosciences, which should have no relevance today. There are some things I'll be talking about which are off-label, which most of dermatology is off-label, so take that what it is. The things I love about dermatology is the skin is so accessible, right? You can see the skin, you can see what's happening, you can see if a patient's getting better, you see if they're getting worse. But it's so easy to study, so easy to look at, and as such, there's a lot of things that are happening internally that manifest themselves on the skin, and I'm lucky enough to be kind of front row to see some of those changes happen. So I want to kind of go over some of those clues, as well as let you know. Most of you will be seeing these things before I see them, maybe helping you understand, maybe where further workup or treatment options or referral might be necessary. So this first case is a case from the last 6 months. He has a 4-week history of a rash on his backside, his elbows, and his knees. Otherwise healthy, no medications, no other symptoms, no other problems, but extremely itchy. He comes into my clinic with this extremely itchy rash. So I asked him if I could share this case today, and he said yes, and then he chuckled a little bit because he realized that he sent me a picture of his backside, and so I found a different picture of someone else's butt, and it's like a butt double. So it looks like this, but this is not his backside. So if this gets back to him, this isn't his backside that we shared. So, but we have this extremely itchy, kind of these grouped little vesicles, kind of in an annular pattern on his butt. On his elbows, this is kind of where they're starting to resolve a little bit, but these crusted, areas on the elbows. He had some areas, of involvement on the. Sorry, these are. Knees and elbows always confuse me. So these are either knees or elbows. I don't remember. But this 2 biopsies were performed, one for H&E, one for direct immunofluorescence, and it came back consistent with dermatitis herpetiformis. So he had no complaints of abdominal pain and no family history of celiac disease whatsoever. His indirect immunofluorescence serum was consistent with celiac disease. Dermatitis herpetiformis, about 90% of these patients end up having, either small bowel biopsy or serum consistent with celiac disease. I think most of them or all of them actually have celiac disease, whether test says so or otherwise. But only 20% of people with DH have any symptoms of celiac disease, which is a little dangerous, and we'll talk about that in a second. So we put them on Dapsone. Dapsone blocks neutrophil chemotaxis, which neutrophils are a big part of DH. And within a week, his rash is gone, right? We talked to him about a gluten-free diet and the importance of a gluten-free diet. Historically, dermatologists would say, hey, we'll just put you on Dapsone, don't worry about the diet, and they do okay from a skin perspective without really realizing what was happening internally to the patient, right? So if someone's eating gluten and they're having small bowel enteropathy or having all the symptoms or, all the problems with celiac disease and gluten consumption, they're having all these other things that can happen as well, right? So uncontrolled celiac disease can have, a malt-associated lymphoma that can happen. Early onset dementia, thyroid disease, kind of a long list of things that can happen if you live your life with gluten allergy that is not controlled. So historically, dermatologists have really done a poor job of trying to get people on a gluten-free diet because Dapsone makes their skin better. But I think we're doing more service to a patient to talk to them about a gluten-free diet. So he did better with Dapsone. He was someone who was committed to living a gluten-free diet and decided just to stop the Dapsone. He's done really well just on a gluten-free diet. The nice thing about it, though, is if he flares up, if he has little flares, he can always take Dapsone for a week. The rash will get under control, and then he can go back to his gluten-free lifestyle. So DH is actually the reason why I'm in dermatology. My wife has celiac disease, and I was lucky enough as a resident, as a medical student, to work with John Zone at the University of Utah, who's kind of the expert in DH worldwide. And it was kind of, I was thinking about doing a number of other things, but kind of got interested in DH and got interested in dermatology, and here we are, right? That's how it works. That's serendipity for you. So this next case, this is a 42-year-old African-American male, has 6-month history of these kind of tender bumps that were spreading within his tattoo. His tattoo had been there for about 4 years. He does have type 1 diabetes, no shortness of breath, no other complaints at all associated with this rash. This is kind of an up close of that, just these kind of these firm little bumps. Biopsy was consistent with sarcoid. And sarcoid could look like a lot of things, right? Sarcoid is like syphilis, right? It has all these different presentations of what it can look like. This is pretty typical, especially within a tattoo. African American skin is a little harder because you can't go off the color as much, but this is pretty typical for sarcoid. So his labs are significant for hypercalcemia, which we see a lot too. We sent him to pulmonology and ophthalmology for for evaluation. 90% of people with cutaneous sarcoid also have pulmonary involvement of their sarcoid, and it's just at what degree is it symptomatic? Is it going to be causing problems? So he went to see pulmonology. This is from yesterday that popped up on my Twitter feed. This is from the JAD. So African American patients are at increased risk of cardiac involvement with their sarcoid. About 25% of them will have some involvement. About 5% will end up having symptomatic involvement with these granulomas in their heart. So, case 3. So this is a patient I've been taking care of for maybe the last 4 or 5 years. 48-year-old Asian American man with a really bad history, long history of atopic dermatitis. Came in to see me and was just in bad shape. He's done light therapy before, he'd done topical steroids, all the things we usually do for atopic dermatitis, and just wasn't getting the control he needed. He had been hospitalized before he came to see me for eczema herpeticum, which is a secondary HSV infection overlying his atopic dermatitis. His history of gout, and he's currently being followed by hematology for polycythemia and thrombocytopenia. He does have a family history of coronary artery disease and MIs in his father and his grandfather. So for the last 3 years, he's been well controlled on dupilumab, which is Dupixent, and had done okay except for pretty severe conjunctivitis, and that's the main side effect that I see with dupilumab is conjunctivitis. Usually we can treat through it, and in his case, he was willing to put up with his eyes being angry with this because his skin was doing okay. But when he came to see me, so first of all, dupilumab works by blocking IL-4, and IL-4 and IL-13 are important as part of that Th4 immunity, right? So when IL-4 is turned up, our Th2 response is also turned up, and dupilumab blocks IL-4. There'll be a quiz on this at the end, so make sure you guys are taking notes. This is really important. So IL-4 also activates the JAK-STAT pathway and kind of increasing these pro-inflammatory cytokines and mediators. So he mentioned when he saw me back in December, he said, my doctor recently added hydroxyurea for my thrombocytosis and my polycythemia. He recently had some genetic testing that showed that he actually has a mutation in JAK2, which is upregulation of JAK2. That receptor is just always on, right? It's always sending that signal. And so we talked to him. I said, well, maybe there may be a medicine that might be able to treat both your atopic dermatitis and your hematologic issues. Anyway, so this is these JAK receptors. He had a defect in the JAK2 receptor, which again made it so it's always kind of stimulating that JAK-STAT pathway. I talked to hematology up at the University of Utah. We said, hey, maybe there might be a 2 birds, 1 stone kind of thing here with this patient. And he ended up being started 6 months ago on ruxolitinib, which is Jakafi, which blocks both JAK1 and JAK2 signaling. Compared to Dupixent, dupilumab, there is a significant increased risk of malignancy, herpes infections, and MACE events in people that are on these JAK inhibitors. I talked to him last week on the phone. His atopic dermatitis is doing fantastic off of Dupixent. His eyes are clear. He's doing okay, but his thrombocytosis and polycythemia is not a lot better, right? It's a little bit better. He's on kind of the max dose of ruxolitinib of 25 twice a day. So I was hoping for a slam dunk. I was hoping to come and talk to you guys and say, hey, this really was a great thing for him. However, because of his the fact that it's not working, they decided to restart hydroxyurea with him. Because of his family history of heart attacks, he's going to be stopping it. And he said, well, let's see what happens, whether I need to go back on dupilumab or not. I think he probably will. I think that once the JAK inhibitor gets out of the system, I think he'll be back in my office and want to restart it. So anyway, not the greatest ending, but I think it's an interesting story. But case 4. So this is a patient with these urticarial plaques on his trunk. There were 2 biopsies that were done. The one that was kind of the lesional biopsy was sent for H&E. The one that was kind of outside the lesion was sent for immunofluorescence studies, and this is how we usually do our biopsies for that. And his biopsy came back consistent with bullous pemphigoid. A lot of times we can treat these patients with prednisone and get them under control and then put them on doxycycline and niacinamide, which seems a little witch magic-y, that it shouldn't work, but for a lot of patients it does. It was working for him initially and then got to a point where he wasn't really responding to that, and in terms of other options, we kind of had to look elsewhere. These are some other patients, not him. These are some other pictures of patients with bullous pemphigoid, more severe, obviously. These kind of urticarial plaques that almost want to be blisters, right? They're almost there, but not quite blisters here. There are some blisters on the arms. These tense bullae is kind of what the typical kind of description are, but we'll see from urticaria all the way to this in these patients. There are a lot of drug-induced cases. Most of my patients, though, they're in their 70s and 80s that get bullous pemphigoid. Most of them are not secondary to medications. Most of them, they say, well, why did I get this? I say, because you got older, and that's what happens sometimes. But these are all medications that can trigger BP. There are cases that do respond to dupilumab, though, because dupilumab blocks IL-4, which blocking that decreases that Th2 response, and they do really, really well. We have a handful of patients on dupilumab. Insurance doesn't cover it. The patients that we have on dupilumab, there are samples that we're getting from the drug companies. But in those patients that are not doing well otherwise, dupilumab is a great option. And I think with time, it probably will get FDA clearance and coverage, for bullous pemphigoid. Okay. This is a 39-year-old patient with a 10-day history of this rash on the legs, also a 24-hour history of crampy abdominal pain and non-bloody diarrhea. Came to the ER after when she's having pain. They gave her pain medicines, but the rash progressed. And this is, by description, what we call palpable purpura, right? These purpuric bumps that have some texture to them, right? Palpable purpura is vasculitis until proven otherwise, okay? So her ESR and white count was elevated. Her INR was also elevated. At this time, her liver and renal function are normal. She did have a biopsy that was consistent with Henoch-Schönlein purpura, which is an IgA-mediated vasculitis, and she ended up going home. She came to the clinic 7 days later, had more lesions. They're more painful, more itchy. Her renal function at this point is still normal. We said, let's start you on prednisone. She didn't want to do prednisone, so we put her on a topical steroid. She came, 10 days later. She had complaints of, large bloody bowel movements and abdominal pain. She was readmitted, and she found to have jejunal interception on CT scan. It's self-resolved, but she was started on prednisone. And if you think about, you have this small vessel vasculitis, and sometimes it's just in the skin, but with HSP, there's that risk of it not only being in the skin, but also being in the gut and being in your kidneys, and that's the real concern, for these patients. With the prednisone, her abdominal pain got better. No more bloody stools. She went home on a 3-week taper. And for her kidney function did remain normal for 6 months. So, HSP, palpable purpura, arthritis, abdominal pain, and hematuria. Renal disease is greater in adults than in kids, and in people who have a cutaneous disease above the waist, which makes sense. You have a rash over where your kidneys are. I think that there's more inflammation there, that it's more severe. But it's very important in these patients to monitor their renal function for up to 6 months. Prednisone has no effect on their what's going to happen to their kidneys, but it's important to keep an eye on them. Usually this self-resolves, and then we just said that, sorry. Okay, we're halfway there. We're going to get there, you guys. So this is a patient that was referred to me for possible amyloidosis. He had complaints of stiff shoulders and kind of tightness in his arms, his face, and his neck. He was a marathon runner, and he found that it was getting harder to move over the last kind of 5 years. He had a history of reflux and had esophageal dilatation. So this is a picture of the biopsy, and you're like, that looks normal. It looks normal, agreed, right? But if you try and pinch his skin, the skin is like, it's like tight. And you just, there's not a whole lot of flexibility, there's not a whole lot of malleability with the skin. Biopsy, well, first of all, so his RMP was elevated, he did have a monoclonal IgA kappa, and there was lytic lesions on his occipital bone. Biopsy was consistent with scleredema. And I've had a couple cases of this, and the second case I had after this is, someone he didn't notice that his back was tight, but I thought, man, you really have a tight back, and his wife's like, yeah, it's getting a little tighter, and also had scleredema. So there's three types, right? There's the type that is seen, related to kind of a post-strep reaction. There is the second type, which is what I've shown you, which is more subtle. It's kind of a slow onset, but it is associated with a monoclonal gammopathy. The two that I've had were associated with multiple myeloma. The patient I showed you ended up having a bone marrow transplant, and his skin went back to normal. The second patient was a little, had some other health issues and wasn't able to do a bone marrow transplant, and he is on chemotherapy, and his myeloma is still kind of smoldering, and his skin's about the same as it was. And then the third type is seen in obese, middle-aged men with diabetes. So we can treat with PUVA. So it's a UVA light with Sorolins, which we do in our office. Cyclophosphamide or cyclosporin can be helpful. If it's associated with strep, it's usually unnecessary. Like I was saying, if it's associated with myeloma, it might get better with treatment of the myeloma. It might not. So I want to go through these. There's a couple things. So kind of divide these up. So there are things that are almost always associated with monoclonal gammopathy. So scleromyxedema, necrobiotic xanthogranuloma, and then a couple of other disorders. Frequently associated with monoclonal gammopathy, scleredema, which we just looked at. So plain xanthoma, angioedema, and Clarkson syndrome. Here's some pictures of plain xanthoma. These may not be visible with the lighting here, but these kind of right here, you can kind of see on the arm, kind of these yellow kind of plaques on the arms. This is on the chest here, kind of these yellow kind of plaques on the chest. They're on the leg, on the neck, and then on the face. This is probably the best kind of picture of that. And this is a patient who did have MGUS. There are things that are there is an association, but not always. So EED, pyoderma gangrenosum, and then subcorneal pustular dermatosis. These are pictures of pyoderma gangrenosum. So these punched out ulcers with kind of overhanging edges, and kind of what we call a cribriform kind of base, where it kind of looks like it's trying to heal in. Again, these are all pyoderma gangrenosum. Pyoderma gangrenosum is a neutrophilic disorder. And pathogens, it can occur with pathogy, which means if you cause trauma to the skin, you can get the ulcer show up where that trauma was, which is why debriding these things is a terrible idea. It just leads to larger ulcers. It is associated with inflammatory bowel disease, myelogenic leukemias, RA. Sometimes we never find out what is driving it, but we try and figure that out. So again, don't debride. They do really well with intralesional or ultra-potent steroids. Immunosuppressants. I don't have this case here, but Dr. Allen has patient with a large PG on his face that's doing really well with rituximab, infliximab. And then sometimes it's occasionally associated with monoclonal gammopathy or sweet syndrome, cutaneous small vessel vasculitis. So this is a 68-year-old male with skin lesions and fever. So these are sweet syndrome, which is similar pathologically to what's happening with pyoderma gangrenosum, but you have these juicy edematous mammillated bumps, right? And these are all sweet syndrome. Usually a fever with these bumps and malaise. They can be post-infectious. They can be secondary to cancers or bowel disease. They're very, very steroid responsive. You put them on prednisone, they're going to clear up pretty quickly. And these are more pictures of that. My time is going to grow short. I'm going to skip through a couple of these. I'm so sorry. Okay. So this is a patient. So this is when I get a call from the hospital and they say this patient has a maculopapular rash. That's a term that we hate as dermatologists, but this is the case that it might be applicable. The term that we like to use is morbilliform, which means it looks like measles. It's a measles-like rash. She's a patient that had been on Bactrim. Her eosinophil count was slightly elevated, but her LFTs are off the charts. Fevers. My first patient that I had as a resident an inpatient that I saw as a resident was a patient that on day 6 dermatology was called for a patient that was on Zosyn and vancomycin and was really sick, was on hemodialysis, was on a ventilator. We showed up and said, well, this is dressed, you need to stop those antibiotics that they had been on, and he died the next day. So this is the one thing that gets my hackles up a little bit. Dress definitely can be deadly. In this case, IVIG reversed her course pretty quickly. A lot of times prednisone works. A lot of times stopping the offending agent is what needs to be done. I'm going to go. This is scurvy, by the way. These little perifollicular hemorrhage, erosive gingivitis. This is an older picture that shows kind of those corkscrew hairs that are really indicative of scurvy. We're going to go through these real quick, sorry. This is another patient that had a history of gut bypass, had 1 to 2 week history of this painful skin eruption, peeling the hands and feet, worsening diarrhea. This looks like flaky paint. That's how I describe it. That's how it's usually described, where the skin just looks like it's just falling off, because it is. But this flaky paint is zinc deficiency. Again, when I was in residency, I had a patient who had severe cognitive deficit and had some abdominal, had some allergies to some foods, and so mom put this kid on rice milk only, and that's all he was drinking and eating, and came in with a rash that was similar to this. So stomatitis is really common, where this swelling of the tongue. Here's her elbows. Let's see here. Oh yeah, okay. Let me do this real quick. This is a good case. So this is a patient with a history of past drug use, but it started using recently, and had this what's called it's like a retiform purpura rash. Retiform means that it looks like the vessels that are underneath there, right? There's kind of this net-like appearance, and it does follow kind of where those blood vessels would be. And these look necrotic, like these look like that skin's going to die, because it is, right? So this is worsening of that same rash. So her labs were, not in good shape. But she likes to hear, and her tox screen is positive for cocaine. So this is a levamisole vasculopathy. I'm surprised we didn't see more of this with COVID. People eating all sorts of weird things for their COVID. But this is a combination of a vasculitis and a occlusive pathology. I saw this on Twitter a couple months ago. This is a patient that had, used cocaine and had levamisole in it. So levamisole is odorless and tasteless for the most part, and they can mix it into cocaine, so the cocaine goes further. So when they're buying this off the street, a lot of times they'll have levamisole mixed in with it, and it causes this nastiness. Ears are a really common location. If you see a rash like this on the ear and the patient has a tox screen that's positive for cocaine, it's levamisole that causes it. You can buy it on Amazon if you guys are interested. This is levamisole. It's an anti-worm agent, which is why I'm surprised that it wasn't used for COVID. People did all sorts of crazy things. And I'm going to skip through this, sorry. Oh, this is, so acanthosis nigricans, right? And we see this all the time. And it can be related to obesity, it can be related to malignancy, it can be related, just family history, or there are some medications that can cause it. This is not my patient's picture, but this is what's called tripe palms, where you get basically acanthosis nigricans on your hands. You can also get it on you'll see AN on elsewhere as well. Tripe is a cow's stomach. The artichoke doesn't have anything to do with this. That's just part of the picture. But they have that wrinkling kind of appearance on the hands. If you see that, that is usually gut adenocarcinoma, or lung cancer can cause this too. So anyway, I'm so sorry I went over. There's a lot of slides.